Senior Care and Lifestyles welcomes you to join us for the next 30 minutes. My guest this evening is Dr. George Ferzli. Dr. Ferzli is a well-known surgeon, Staten Island, Brooklyn metropolitan area, and is also known for his work in many countries throughout the world. And welcome, Dr. Ferzli.
Thank you, Maria. Good evening.
Good evening. Dr. Ferzli has been our guest before, and we have him back again because we have many interesting topics that we want to share with you. Tonight we're going to discuss a variety of topics. We're going to talk about the hiatal hernia, GERD, heartburn, some testing, and I'm sure that it's going to be an eye-opener for everyone. So, Dr. Ferzli, would you like to start with hiatal hernia, or where would you like to start?
Well, okay. I mean, we can define the hiatal hernia and where it's located. The very first thing that sometimes patients get a report of a CAT scan, and it reads small hiatal hernia, and they think it's in the groin, in the belly button, and they don't realize the hiatus is a gap. And if we look at the diagram that we have, it's actually our chest is separated from the abdomen by the diaphragm. And through the diaphragm, we have the aorta that goes down, we have the esophagus that goes down. The esophagus is a tube that when we swallow, the food goes down through this tube called esophagus. Below the diaphragm, we have a certain length of esophagus, and then it joins into the stomach. If we look over here, actually, we have more or less a tube. When we swallow the food, there is contractions of the esophagus that pushes the food down to below the diaphragm, and then it goes into the stomach. Now, going back to the definition, if you want, or the understanding,
Right.
as you asked, the hiatus is in this area, and it's a gap. It's a hiatal hernia, therefore, is a hernia, which is a defect, or if you want, a protrusion, in this area, at what we call the gastroesophageal junction.
Right where they join together.
Right where they join together, yes, indeed. And that hernia, you mentioned actually heartburn. We can have, the heartburn is different than the hernia. They can both be together, meaning by that I could have a hernia like you see here, where actually this illustration demonstrates well the hernia, meaning by that the diaphragm, the opening is wide, it's not small.
Right.
The esophagus stopped in the chest cavity. So the stomach came up into the chest.
Okay.
So this is a type of hiatal hernia, and as we know, there are different types of hiatal hernia. This is called, for example, the sliding hiatal hernia, where the stomach went up into the chest.
Right.
Now, this hernia may have heartburn, or it may not have heartburn.
So if you don't have to have heartburn with hiatal hernia.
Exactly. I could have heartburn without a hiatal hernia. I could have a hiatal hernia without heartburn, or more commonly, I will have both of them together.
Right.
Every entity has a different presentation in the symptom.
So, okay, so I'm sure that it's information for our audience is that opening that stomach can go right up into that opening.
Exactly, yeah.
Right.
What happens is that usually, I mean, let's look at the normal mechanism. When I swallow and the food is going down the esophagus, there's a sphincter here. We have it presented as a valve that's keeping the thing, after it passes food, it closes up. We have here what we call a lower esophageal sphincter, which has a certain pressure to maintain it closed. The other mechanism of protection against reflux, if you want, or heartburn, is the presence of a length of esophagus within the abdomen. This 2 to 2 inches of esophagus below the diaphragm causes the esophagus to stay closed to prevent reflux. And then in our anatomy, we have a certain angle here between the esophagus and the stomach. You see there is a little angle here.
Yes.
That angle is known as the angle of His, H-I-S. And that angle also is among the mechanisms that prevent the reflux. Lastly, there is also a membrane here between the stomach and the diaphragm. There are kind of attachments that will prevent also the reflux and the stomach from sliding up.
Okay.
Now, this is our normal anatomy. And then when the food reaches the stomach, we're supposed to empty from the stomach into the duodenum properly.
Right.
Okay. So at any moment somebody presents with a heartburn, then we have to ask the question, why is he having heartburn? What causes heartburn? Let's define that, because people usually don't have a good understanding. When the acid, because in our stomach we have acid.
Right.
When the acid is refluxing, it causes heartburn. So for example, this is something common in newborn and in children.
That's on my list to ask you, yes.
Yeah, I mean, a lot of little babies, when they are born, actually, they have sometimes lung problems, sometimes they have wheezing, and immediately we discover that it is actually the acid reflux that's coming up into their throat, giving them severe pain. They're all the time crying, and it takes sometimes and they outgrow it. Most of them outgrow it without any intervention, by just changing the formula, making it thicker, having the baby sleep
with it elevated,
head up,
yeah.
or like in an adult. We can help with that, even sometimes medication, to address this reflux that comes up. On occasion, actually, sometimes in adult, the voice could be hoarse, and the person has been to an ear, nose, throat, trying to find out why their voice is changing, why is it hoarse. Sometimes a cough, a chronic cough. Person has been to the lung doctor, is at chest x-ray, CAT scan of the chest. They've ruled out pneumonia, they've ruled out pleurisy, they've ruled out all those things to finally realize that it may be the acid refluxing all the way up into the vocal cords and causing the cough or the voice changes. So the symptoms could be subtle, could be up here, or could be severely, where the most common one is, right here, where the person gets this heartburn. This is why it's close to the heart.
Okay.
But it's a burning sensation.
Yes.
Now, it depends how severe it is. Then the person will seek medical attention, or like years ago, they used to take some Tums.
Right.
They used to take some...
My father took Tums all the time.
Exactly, in order to, they call it indigestion, and they don't really go any further than that.
Right. It was always classified like a blanket. Everything that bothered you was indigestion.
Indigestion.
But today you'll hear people talk, most of them say, I have heartburn,
That's
you
right.
know? And then I guess if the Zantac or the Pepsid or the Tums don't help, then they have to go to the next step.
The next step is actually when it becomes severe and recurring and really bothersome. I mean, sometimes it really affects not only the sleep, like we said, the voice, the cough. It becomes severe pain. Sometimes even it mimics heart attack or chest pain. At that point, an evaluation by a doctor has to be done. When those things don't help and it's being chronic and recurrent, sometimes women, for example, on some occasion it's transient. For example, like we said, in the newborn, the little baby, they outgrow it. A woman during pregnancy, when she's carrying a large baby, or even just pregnancy, the pressure of the uterus on the baby can push things up and dilate things, and she may get heartburn. That is transient. In other words, more than likely after delivery,
it'll be gone.
And the intra-abdominal pressure is reduced. She may not have as many symptoms. Otherwise, in any other individual, then they need to get an evaluation. Well, the first evaluation, if you want, in the testing, is to do an upper endoscopy.
They're done frequently. Everybody today knows what that is.
Again, it's basically putting a scope through the mouth into the esophagus, coming into the chest.
Right.
Now, this is usually done by the gastroenterologist. And when the gastroenterologist puts the scope in, he's looking for a lot of things to help with the diagnosis of hiatal hernia or heartburn. First of all, they're looking to see where is this junction.
How far down do they go?
Exactly. Well, they measure. Oh, they can go with the scope. They can go all the way down. You know, usually they go, first of all, they check for H. pylori, which is a bacteria that can cause ulcer and can cause actually cancer. And that, although it could be diagnosed with breast test, they do it with the scope, because if H. pylori is detected, then the gastritis, which sometimes could be the cause, is treated with antibiotics, and then the H. pylori is gone. This is first step. Then as they're going in, they're looking at the inner lining. I will go back to your distance in one moment, Maria.
Sure.
They're looking at the inner lining of the esophagus to see if there is esophagitis. What is esophagitis? Inflammation of the inner lining of the esophagus. Because if I'm having acid refluxing, I could have a minimal esophagitis, minimal inflammation, or I could have a severe one with ulcerations So the gastroenterologist will look with the scope to see are there ulcers already. Sometimes it's very advanced that it has started to scar down to cause stricture. But more importantly, when he's looking at this, he has measured the distance to see if this is, for example, 35 centimeter, 37 centimeter from what we call the incisura. That means that it is above or below the diaphragm.
Right.
But very importantly, before he leaves this area, and he has checked for esophagitis, he has checked for retained food, he has checked for ulcer or stricture, the gastroenterologist will do a biopsy in 4 quadrants of the circle of the esophagus. We call that 4-quadrant biopsies. Why? What is he looking for? He's looking for something very common, actually, called Barrett's esophagus. Barrett is the name of the surgeon that originally from Australia and then in England had described. As we're getting the acid refluxing, over the long period of time, the inner lining of the esophagus will change to what we call different level of Barrett or precancerous condition to cancer. Because the acid, as it's refluxing, the lining of the esophagus, the cell, will change to become what we call columnar epithelium from squamous, meaning by that it has changed to a lining like inside the stomach. And often the Barrett is benign, but there are different type of Barretts, short and long segment, but more importantly, if there is precancerous, that becomes a whole different entity now. We're not anymore worried about just hiatal hernia, we're worried about a disease that is a result or associated with reflux. So as he continues the upper endoscopy, he will see where the junction is. And then if there is a hiatal hernia, he's going to be able to measure it more or less, to say small hiatal hernia, large hiatal hernia. Sometimes when this, which is a type 3, as we call it, a type 4 hiatal hernia, not just a simple sliding type 1 or 2, sometimes the entire stomach, and that happens mostly in elderly women over the years, and the stomach is sliding up. Often the entire stomach is up, some of the colon is up, some of the solid organs are up through the large opening in the diaphragm.
From it not being diagnosed.
They start sliding up. And then sometimes on the simple chest x-ray, before even doing an upper endoscopy or any test, you see the stomach bubble sitting in the chest. So you already made your diagnosis. This is a very advanced, and they may be with no symptoms, believe it or not. The only symptom that they will present with is that they have like COPD or emphysema. They are short of breath. They can't. Why? Because
pressure.
Bravo, yeah. The stomach has occupied or is pushing on the lung, giving them this shortness of breath from this large entity that is occupying a part of the chest. So as he continues down, the gastroenterologist, to finish with his testing, he's done the H. pylori, esophagitis, Barrett, precancerous. He will see if the sphincter is tight or not, the size of the hiatal hernia, and then he will come to the stomach. In the stomach, obviously, we're not going to go to, he's going to look for polyps or tumor or whatever, which has nothing to do with our topic tonight. But more importantly here, what do I want from him to tell me if there is retained food in the stomach? Why? Because usually I haven't eaten from the night before, right?
Right.
There should be no food particle in the stomach. If I see food particle in the stomach, what does it mean? That my stomach is not emptying properly. And if it's not emptying, I have a problem with the emptying. What will happen? Then I will back up.
Right.
So the presence of food particle will alert us to the possibility that the problem of the reflux and the heartburn may not be here. The problem is here. You're not emptying. You follow what I mean?
Oh, yeah, absolutely.
So all those things are obtained from the test of the upper endoscopy. Based on this result, we will decide whether there is need for H. pylori treatment, the medications that you ask about, avoiding alcohol, avoiding coffee, avoiding chocolate, avoiding citrus, sitting up, taking some medication twice a day, that what we call proton pump inhibitors, which are the medications that will stop the secretion of the acid in the stomach. And then if the patient is relieved with these medications, then there is really no further thing to be done except for surveillance. For example, if they do find a Barrett, we have to do endoscopy almost every year. in order to make sure that the Barrett is not progressing from a benign disease to a precancerous disease.
Right.
Otherwise, the gastroenterologist, and that's why over 40 million Americans have heartburn or combination of heartburn and hiatal hernia. This is a very common problem. And certainly not all of them need a surgeon or need any surgical intervention. Nowhere near even percentage of these 40 million people. Okay?
Right.
So that, if you want, a little bit of the beginning of the workup, as we show here, that the other test that could be ordered along with the upper endoscopy that goes along with it is what we call a barium swallow. I'm sure you've had patients who've had barium swallow.
Absolutely, yeah.
And what the most important thing when they go to get the barium swallow, and this is very important for the people to know, if I go and I order a barium swallow on a patient in whom I'm worried about reflux or heartburn, the radiologist may not know. He may do the test with the patient laying flat, for example. That's not going to help. The test will be done with the radiologist looking at the patient as they are swallowing in the standing position first. So as I'm swallowing and standing,
Right.
I want to see if there is a hernia. All right? And then if there is a reflux in the standing position. If the chalky material, the milky type material, this is a barium swallow.
not
They give
good
you a
tasting.
glass to drink.
Right.
Doesn't taste great, but I mean, you drink it, and then they start inclining you to see if with the positioning of the patient,
If it moves.
bravo, if the liquid is refluxing. So that will give us more information about the size, the junction. That's where the barium swallow is even more important than the upper endoscopy. It will tell me where the junction is, at what level above the diaphragm, if this angle is distorted. Because when the stomach comes up, there is no more angle. This sphincter, you follow what I mean? So that is the information derived from the barium swallow that will complement the upper endoscopy.
EGD.
And we stop at that level and decide if medical therapy is successful or not over a certain period of time.
Okay. All right. That's very clear. You did say that the sliding hernia was one type. What is there?
Well,
not?
1, 2, 3, 4,
Right,
actually,
right.
depending on how large it is and how much is slid up, and if there are other organs coming. The most common one, 1 and 2, are most of the time treated with medication, and they respond very well, and most people do not really need any major surgical intervention. There has been some new modalities to address type 1 and 2 endoscopically, meaning by that, this is actually within the past 5, 6 years. I go in through the scope, and I could clip and clip and narrow and create an angle. Actually, I can come in, go back up, and then clip and recreate the angle. But those type of procedures endoscopically, you know, through the scope from inside, are mostly for type 1 and 2, meaning by that the small hernias.
Right.
They cannot address yet the
larger
hernia.
ones.
Yeah.
Right.
Now, there is another type of hernia that takes place in this, which is treated the same way, but with surgery. It's paraesophageal hernia. That's not hiatal hernia. What does it mean? It's simple to understand. We said this is the diaphragm. And we saw that the opening here, where the stomach went up,
Right.
it went up through through this orifice. In a paraesophageal hernia, this junction stays here, where it is,
Okay.
but the stomach comes up.
Okay.
You follow what I mean?
Yes.
Paraesophageal. Remember, para from the Greek means next to.
Right.
So a hernia next to the esophagus is a paraesophageal hernia. What can slide up through the hole next to the thing, and then while the junction stays here, is a paraesophageal hernia. Now, this hernia type should be operated on, because that stomach, although this could incarcerate and strangulate.
That's what I was going to say to you. I'm thinking that it's going to close off and,
exactly.
and get
And then it becomes
incarcerated.
an emergency where you cut the blood supply, and then those are actually an indication for surgery, rather than just conservative treatment and medical therapy over an extended period of time.
The para is not as common as the regular.
It's not as common. The
Right.
most common one is hiatal hernia type 1 and type 2.
Right.
And over the years, obviously, from lifting, from coughing, from constipation, from smoking, from many other factors that induce intra-abdominal pressure, it starts to slide up more and more. Okay.
Yes, I was going to ask you the causes. We did mention most of them. The most common cause, is it from lifting or is it from a combination?
You know, it could be congenital. I mean, you could have a large opening
Right.
to start with. It could be from some systemic disease, what we call collagen disease, which
Right,
are very
right.
rare,
Yes.
Marfan syndrome or so forth. But in general, it is, I mean, there's really no pinpoint etiology. I mean, we're talking about the hernia now, not the
Right,
heartburn.
right.
I mean, because the heartburn could be from alcohol, could be
Right.
from chocolate, it's a different story.
Right.
All the good things cause heartburn.
Yes, and many other problems.
And many other problems. But
But for the hernia, because you see so many, you know, people say they got a hernia because they were moving in the process of moving.
Because when you're doing what we call the Valsalva maneuver, that's exactly the name of it. Anything that will contract the diaphragm,
Right.
be it vomiting,
People
be
that
it
have
severe
constant
lifting.
constipation.
Exactly, you're stressing this area. Really, you're trying to dilate this area, and by dilating this diaphragmatic opening, you're inducing a potential, hypothetical, sliding up or causing herniation with or without reflux.
Okay.
Yeah, obesity, for example, is another factor, so a lot of factors.
Is there any one particular gender that's at risk, men more than women? It's
Again, it is debatable, depending what type of hernia we're talking about. Yeah. Yeah.
okay.
So,
The dividing line, patient has been suffering, they had heartburn, it goes a little further, they can't get rid of the pain. When does the patient or our viewers, anybody that says, oh, I have that problem for years,
Yeah.
when do they call the physician? What pushes them
That's
over?
actually the heart of the thing, is that if the person has taken medication, let's say a young person, here the age comes in, for example, let's suppose I have a 30-year-old who's been now taking the proton pump inhibitors for the last 10 years. How long are they going to continue taking it? And at some point, we have to draw the line and then to move on to see if there is another alternative of treatment, being the endoscopic one or, as I will mention, the laparoscopic one. If I have a person that's 70-year-old and then is just starting to take the proton pump inhibitor and is relieved by the symptom, I'm certainly not going to ask them to go anything further. So, prolonged medical therapy, failure of medical therapy, meaning by that I give you the proton pump inhibitor, I increase the dose, and nothing happens.
Right.
So now what do I do? And this is really where we see us surgeons, mostly the patients. So the patient comes in, actually, and they have taken either over a long period of time and they are relieved, but their endoscopy is showing progression of the Barrett or more heartburn. At that point, I, as a surgeon, before I discuss with them, and then I really want to make sure that the surgery is indicated. Because if I have one message tonight to share with the audience, if the surgery is going to be indicated for hiatal hernia, it is the proper indication that's going to give us the proper result. This is the one area where if the surgery is not is done without the proper diagnosis made, it's really, really a big problem and a nightmare to the patient, the surgeon, and the endoscopist. Okay, so immediately we go to the two other tests, which are really the essence of making the diagnosis. One is esophageal manometry. What does it mean in simple terms? The gastroenterologist does it nowadays with impedance. We can do it in 15 minutes rather than 45 minutes. They can measure the contractility waves of the esophagus.
Right, I see that.
Right. Why? Because often we have esophageal poor contractility. And that could confuse the symptom with heart attack or reflux.
Right.
And if that is a problem, think with me. If this is not contracting properly, and I come to fix this area, I'm going to make him really miserable. The second test, after the manometry, it will tell me about the sphincter here. If it's weak, that means it's open, it's not closing, that means that acid is refluxing. This is from the manometry. I'm looking at the pressure of the sphincter, the closure mechanism, and the progression, the propulsion of the esophagus. The most important test, which is really the most important one, is something called 24-hour pH. Now, up until recently, the way we did it is we put a probe in for 24 hours, coming out of the nose, connected to a monitor. I mean, it's terrible for the patient. And that probe, every 5 centimeters, every 2 inches, detects the acid level, exactly like you do in an aquarium.
Right.
Is it below 4? For how long did it last? Did it occur with the patient sleeping? Did it occur with the patient standing? Did it correlate with the patient's symptom? And at the end of the 24 hours, we take the monitor and the probe out, and we go and we computerize the data, and then we come up with a score called the DeMeester score from Tom DeMeester, who is a surgeon in California, who took 50 normal individuals and averaged their components, and then we make a comparison too. If the DeMeester score is over 14, this patient needs an operation.
Okay. Well, you know what? Hearing that test, I think I would just call you and say, Dr. Ferzli, I need surgery.
No. Right now, to make it simpler for the patient, actually, this test is done not anymore with the probe. It's done with the capsule.
Right.
So the gastroenterologist goes in, clips the capsule at the end of the esophagus, and that capsule wirelessly transmits the pH level. After 24 hours, we come up with the DeMeester score. If it is indeed above 14, then we have to sit down and discuss with patient the surgical alternative treatment to his heartburn.
Okay, and believe it or not, our time is up.
Yep.
I'm sorry, it went so fast. So thank you very much. And audience, we want you to know we're going to have a part 2 series and talk about some more hernias. So everyone, thank you for joining in and have a good night. Good night.
Thank you, Melanie.
Thank you.